Oh, good afternoon once again, everyone. The recording has started, and we are back at the Finance Technical Advisory Committee, this committee to the Universal Healthcare Commission. This is our November meeting, and I will turn it over to Ross Valori to call the meeting to order.
Thank you, Mary. Welcome, everyone. Thank you for joining us today for the November 6th meeting. It is now 2:01, and I will call the FTAC meeting to order. A quick plug first. As we mentioned last month, or in the September meeting, I apologize. We are looking for an FTAC member to serve as FTAC lead. Previously, Pam and David had served as FTAC leads and had a huge hand in shaping the work that we're doing. And we're looking for a volunteer to serve in that role again. And I just wanted to quickly solicit and see if anyone is interested in the very prestigious position of FTAC lead. Well, if folks would like to think about it a little bit more or have questions, you know how to get a hold of us. And we'll continue to reach out and solicit. But yeah, just really appreciate if anyone is believes that they have time and capacity to do that. It is a really important role and really helps shape the work that we do both in FTAC and on the commission. So we'll be reaching out again about that. Call for applications to fill the open FTAC seat closed this past Monday, and happy to report we received 6 applications, which is excellent. The commission will appoint a new FTAC member by majority vote at the next meeting. I also have some sad news to share, but also exciting. Bittersweet is maybe the right word. Allie Power, our fantastic policy analyst, is this is going to be Allie's last meeting. Allie will be moving on to a new role in another state agency later this month. We'll keep the committee and this commission updated on plans for staffing as we move forward, but just wanted to say, an enormous thank you to Allie, who's done so much in guiding the work of FTAC and the commission and just always being positive and interested and engaged. So just thank you so much, Allie. Is there anything you'd like to say briefly?
No, that was great. Thank you, Ross, and
Okay.
thanks everyone for working with me over this last year and change. I've had a great time, and I'm going to miss you all very much, and probably still tune in or watch the recordings on YouTube because I'm excited to see all the good work you continue to do. So thanks.
Thank you, Allie. Well, next up, we'll move to roll call. When I call on you, please unmute your microphone and let us know that you're here. Christine.
Here.
Thank you, Christine. Eddie.
Present.
Thank you, Eddie. Esther. I believe we were told Esther is not able to attend today. Kai Young, we were also told that Kai will not be able to attend today. Matthew Morrissey.
Present.
Thank you, Matthew. Good to see you. Pam.
Present.
Thank you, Pam. Robert.
Present.
Thank you. And Roger.
Present.
Excellent. With that, it appears we have a quorum. Thank you. Now we'll move to adopt the September meeting minutes, which is included in your packet. I believe that is is that tab 2, Mary? My apologies.
I think it's tab 1.
Tab 1.
Yeah,
Okay. Excellent. Sorry. Is there any discussion of the minutes or proposed changes that anyone has? Not hearing any. Is there a motion to approve the minutes?
I'll move approval.
Okay. Pam moves for. Is there a second?
Second.
Thank you, Robert. All in favor, say aye.
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 Any opposed? The motion is approved. Thank you all. And next up is public comment with Mary. Send it back to you, Mary.
Thanks, Ross. Since our last meeting, we received one written public comment. It's in your packet. It included recommendations for provider reimbursement and participation and included some guiding principles. So thank you for submitting that comment ahead of time. And now we're going to start out with people who signed up in advance to provide oral public comment. And then from there, once we had 2 people who signed up. From there, we will then open it up to folks who might want to raise their hand. So 1 minute, 30 seconds. And when you begin speaking, please identify your name and your organization. And I don't know if you've been moved over to panelists just yet. There's always a few seconds where it takes a few seconds where you don't hear us and we don't hear you. But our first person is Ronnie Shore. Is Ronnie here today?
I don't see Ronnie, but I moved over Maureen.
Okay.
Great.
Thank you. Okay, we will go to Maureen next, and then we'll see if Ronnie's able to join us. Maureen Brinklund.
Hi, my name is Maureen Brinklund, and I'm the co-chair of the HUC subcommittee for the coalition known as Healthcare as a Human Right. And I want to thank everyone again, this FTAC committee members and your staff, for the steady commitment to what I think is really important work for Washington State residents. And I've kind of met Ross and Mary and Allie. And Allie, I just want to wish you all the best in your move. And I'm really sorry to see you go. You were so very helpful all through the summer months when we did the roundtable and many other opportunities to meet with you. I incidentally also stay in touch with other organizations that are part of our coalition and are advocating for healthcare access, affordability, and equity, including North Seattle Progressives, the League of Women Voters, and Wallingford Indivisible. And when I can, I share news with folks in those groups about the commission's work. My question today just has to do with the work plan. And I was looking at the work plan status chart with some other people as well. And the 2 items that are coded as completed / straw proposal adopted. Since I don't know what the completed version looks like or amounts to, I searched today's meeting materials for those terms, eligibility, benefits, and services, but I didn't find anything that described the completed items. Without going back to the previous meeting notes, I'm wondering if these completed items will be described in next year's annual report. And it looks like I've got a 0. Is that timeout? So I'm looking for a way to describe or say translate these terms to other folks as I talk to them. And I'm guessing that it's going to be in this year's report, so I'll look there. Thank you very much.
Thank you very much. I'm looking again for Ronnie. I don't see him here.
I don't see Ronnie.
Okay. Well, then we will see if there's anyone else who has joined us who would like to make a comment. If so, just please put up your hand in the Zoom function and we can move you over. Oh, there is one hand. Andre Stackhouse. Let's see.
Can you hear me?
Yes. Okay. Then also I should mention we're a bunch of pinch hitters today. We've kind of had to shuffle our staff and shuffle our duties. So we might be, it might take us a few extra seconds, but we're getting there. So yes, we can hear you, Andre. Thank you.
Okay, I'm not sure why I can't turn my camera on, but hello everyone. Andre Stackhouse here representing Whole Washington today as Executive Director. I'd like to start by thanking the Commission and FTAC for their ongoing review of the Washington Health Trust. We are eager to incorporate the feedback in your annual report into our legislative development. I'm glad to see FTAC developing its core principles regarding provider reimbursements, starting with the review of the Washington Health Security Trust from our allies at Healthcare for All Washington. For comparison, the Washington Health Trust would set reimbursement rates based on a collective bargaining agreement between its governance board and participating providers. While no provider would be required to accept coverage through the WHT, inclusion at the negotiating table is a strong incentive to be a participating provider. The governance board would also create providers subcommittees for the purpose of maintaining alignment with medical providers. As the Commission knows, the Washington Health Trust is the most current universal healthcare legislation introduced in the legislature and remains under continuous development. It has been endorsed by providers, including Link Community Clinic, as well as unions, including SPIA and IBEW 46. We ask that the Washington Health Trust remain a primary point of reference for FTAC and the Commission on reimbursement rates and universal healthcare system design. We also invite all members of the Commission and FTAC to participate in ongoing universal healthcare stakeholder meetings being held by Senator Hasagawa, the next of which will be on November 17th at 1 p.m. with virtual attendance as an option. Please email andre@wholewashington.org if you would like to be added to the invite. Thank you, and we look forward to our continued collaboration in 2026.
Thank you. Is there anyone else who would like to speak? Please put up your hand. Oh, I am not seeing anyone else. So I think perhaps that wraps up our public comment. Thank you all so much for participating today. As a reminder, we welcome and encourage public comment. We appreciate any feedback received. It's an essential part of the process and gives us a good opportunity for the public to have their voice heard during the regular meetings. The actual oral public comments are only during the meetings, but you can always submit comments or contact us through the FTAC mailbox, which is HCA Universal FTAC at hca.wa.gov. And next, I think Evan is here. We're going to hear from Evan Klein. There were some questions about reference-based pricing in Washington at the last FTAC meeting, and so we've invited Evan to give us an update. So, Evan.
Hey, good afternoon. Evan Klein. I am the Special Assistant for Legislative and Policy Affairs here at the Washington State Healthcare Authority. Thank you for having me with you today. Mary, I just want to check if you will be running through materials on your end or if I need to share my screen.
Audrey has it all under control.
Perfect. All right, well, you can jump into my presentation. I have a couple of materials here for you really to focus on some of the work that we've been doing here at the Healthcare Authority to start implementation of what was kind of termed during legislative session, Senate Bill 5083. It was our state's next step towards advancing reference pricing across some of our publicly purchased programs. I know we've talked with the Universal Healthcare Commission about this a bit, and I know some of you were directly involved in some of the legislative efforts this session. So thank you for all of the engagement with the agency throughout this process. And here to give you a bit of an update today. Also happy to take questions throughout if I can be helpful. So you can jump to the next slide. So as I mentioned, just want to provide a bit of a background on where we are with our PEB and SEB access and affordability policy, a summary of the bill, a little bit of a status update on rulemaking and some updates around expected impacts. I'll note that some of the analysis that I'll talk to throughout this presentation kind of remains from our work done during the state legislative session and in advance of the legislative session. We're in the process right now of updating some of the projections, particularly related to the cost containment that we believe will occur as a result of this policy and in relation to recent contract changes and reimbursement rate increases that have occurred in our PEB and SEB programs. So that delta kind of growing over time and should have updated numbers here in the next couple of months, but just acknowledging that some of that analysis is in flight and isn't necessarily reflected in this presentation. Next slide. So by way of background, the reason why we continue to step into this space as a state is a couple-fold. And these concepts, I imagine, are not unfamiliar to you all here at the FTAC. But recently, we've seen an increase in contract termination notices by large health systems, kind of the generation of leverage in contract negotiations. Hospital services continue to grow in unit price. So we have seen kind of general cost growth, including utilization, which has been impacting consumer premiums, and that's across markets. We see it specifically in our Medicaid and PEB and SEB programs, but we know it is similarly impacting our individual and small group markets, as well as large employer coverage. PEB and SEB rates specifically had grown by around 20% from 2021 to 2024. And for 2025 and 2026, we've seen consistent growth in premiums as well. outpacing inflationary rates for the economy writ large. In Washington, we also had some significant investments in our Medicaid program in 2024 related to hospital payments through our state-directed payment, known as our hospital safety net assessment. Obviously, and I can speak to this a bit, but there are some implications as we think a few years down the line related to restrictions that were placed on state Medicaid programs by HR 1, which was passed earlier this summer. So after Senate Bill 5083 was enacted by our state legislature, that will certainly complicate how the state proceeds with kind of equalizing payment and managing reimbursement rates in the Medicaid space. But just acknowledging that we were thinking about these policies at a time when the state was similarly making investments in areas where historically we've seen reimbursement at much lower rates than in commercial insurance. And then we also decided to really kind of step out in this space for public and school employees in relation to work that was taking place in Oregon, have the benefit of seeing them kind of go first and see the benefits and successes related to their reference pricing program with their public employee and school employee benefits down in Oregon. They have a policy that's been in effect since 2019 that we were able to work from and really learn from. Next slide. So this is kind of the last bullet on the last slide, but just the context here as well is we know that primary care and preventive services, inclusive of behavioral health services, the reimbursement for those services has been lagging behind. So as we've seen significant cost growth overall and price growth, particularly in hospital settings, that has not been consistent across the healthcare delivery system. And so part of the theory behind the policy that we have in place now is that we can try and redistribute reimbursement, equalize payments, move money towards those services where reimbursement might be lacking and where we are trying to generate increased access and utilization. We see this as in line with the goals set forth by our state legislature to increase kind of total spending on primary care services to 12% of total healthcare expenditures in Washington. We know from a 2022 all payer claims database analysis that we're only spending approximately 5 to 6% towards primary care today. The cost board, our state's cost board, recommended adoption of numerous policies to increase primary care expenditure, including through reference pricing. And so we saw this as an opportunity not just to create cost containment, certainly one of the overarching goals of the policy, but also to reinvest funds in our preventive services. As you can see at the bottom, primary care reimbursement for PEB and SEB on average was around 111% of Medicare as of 2023. We've seen some of those reimbursement rates increase over time, which is a good thing. So in our base data, right, we have seen our carriers and we as a state have been investing in primary care, but still a ways to go and not necessarily consistency across providers. Next slide. The same story is largely true in the behavioral health space. We know that access challenges are well documented. We experience this acutely in relation to our state's Medicaid program and managing access for our Medicaid clients. But we know that this is a kind of persistent issue across commercial insurance as well. Reimbursement rates for inpatient and outpatient mental health services, for example, in facility settings, tend to be in the 140 to 190% of Medicare range. But for professional fees, are closer to 88% of Medicare. And this is really thinking about those clinical services, those preventive services outside of a facility setting, which are more kind of preventive in the behavioral health space. And so we are contemplating, or through the legislation, again, contemplated setting a payment floor for behavioral health as part of that ethos of redistribution towards preventive care. Next slide. This is a policy. So as I speak about 5083, just acknowledging that we are kind of parlaying this with other policies that are already in effect here in Washington. So Washington's Cascade Select program, which I know you all have discussed in the past is our individual market public option program, which was enacted in 2019. The first plans of which were offered in 2021, caps payment for all services in the aggregate at 160% of Medicare. So leverages reference pricing kind of as a concept to contain costs for our individual market plans, but a slightly different structure. And so I'll talk to that here in a second, but thinking about total services, aggregate services, and without specific caps on certain subsets of services. The good news is Cascade Select plans were available statewide in 2025, and the lowest cost silver plan in 31 counties. We've seen some migration in primary care reimbursement up towards a 135% of Medicare floor that was established for Cascade Select public option plans. But we've also seen some kind of unique dynamics where within that cap, there was still kind of room to evolve as a state and thinking about the reference pricing policies that we want to utilize. And I know our friends and colleagues over at the Health Benefit Exchange are continuing to think about how the Cascade Select program can evolve in the next few years as well. Next slide. So that brings us to this past legislative session. We ran a bill, Senate Bill 5083, as agency request out of the Healthcare Authority this session, which we had the pleasure of shepherding through the legislative process and seeing enacted earlier this year. It's been codified now in RCW 4105-028, so it is enacted statute going forward. We're in the process of rulemaking under the legislation, and I'll get into that here in a second. The legislation does not take effect until January 1st of 2027, but we are kind of well underway, kind of processing what implementation and enforcement will look like for this program. 5083 applies to fully insured and self-funded medical plans under our public and school employee benefits programs. For reference, that's coverage for over 500,000 Washingtonians, teachers, school employees, all of our public employees. It caps carrier reimbursement for inpatient and outpatient acute care hospital services at 200% of Medicare beginning in 2027. And so, as I mentioned, slightly different structure here than we've seen implemented in our Cascade Select program. As opposed to looking at aggregate services statewide, this is a focus on inpatient and outpatient acute care hospital services. Again, setting that cap generally at 200% of Medicare. There are some differential caps for children's hospitals in Pierce and King County. So this is Seattle Children's Marybridge, setting those caps at a percentage of Medicaid ratio of cost to charges. That's what RCC stands for. It is a Medicaid payment policy that we utilize in some instances in the Medicaid program. It's paying a ratio of a facility's published costs. And so slightly different kind of cost containment mechanism for children's hospitals that was negotiated during session that kind of breaks from the mold for other acute care facilities. And then there are a number of hospitals that are exempt from this kind of payment threshold. Those are mostly critical access and sole community hospitals, so some of our smaller rural facilities in the state. And it's important to note here that hospital reimbursement caps, or these payment thresholds, exclude professional fees. So this is specific to the facility charges, which tend to be the bulk of the charges on a patient's bill, but noting that professional fees would sit outside of these payment caps. There are also some caps in the legislation on out-of-network reimbursement for acute care hospital services. So for those who might have been following the legislation when we originally proposed this, it was a policy that would require participation of hospitals in the PEB and SEB health plans when there was a good faith offer to contract by one of our carriers or our TPA regions for the UMP program. That was included in the legislation because we've acknowledged throughout that reference pricing or any payment controls really have to come in line with some policy to think about network access. If we only try to contain costs, but don't do anything related to kind of the broader contracting to develop networks. Our fear is facilities will leave networks, and you kind of imbalance that dynamic where we're both trying to create affordability, but also ensure that clients can access services. So that was our original attempt at kind of managing that balance. We inevitably moved the policy towards this out-of-network reimbursement cap. This is a policy structure that is in effect in Oregon. Then they've leveraged kind of a lower reference price cap for out-of-network services in the attempt of creating an incentive to keep hospitals in network and keep networks robust. In Oregon, they have seen that policy play out effectively with no major hospital systems leaving health plan networks for their public and school employees. Obviously, we haven't yet seen what implementation will entail here in Washington, but we remain hopeful that the structure of the policy overall will allow for our carrier partners to maintain robust networks for PEB and SEB enrollees. Next slide. So just to continue, also noting that we had included in the legislation reimbursement floors or kind of separate payment thresholds for primary care and behavioral health services at or above 150% of Medicare levels. So it requires our carriers to ensure that reimbursement kind of remains adequate for those services. And again, you see some redistribution. So our cost modeling shows that we're containing costs overall by reducing expenditures in the hospital setting, but then we're increasing expenditures for primary care and behavioral health. So some redistribution there. Overall cost containment, but some investment in our preventive services across the state. It requires our carriers and our TPA to take into account these changes in reimbursement and future rate development cycles. So the goal here being that these any savings generated to the state be passed along to consumers, and so that is how the policy has been structured, and requires some reporting by the Healthcare Authority in 2030 and 2034 on the impacts of the legislation. So we know that it's important to shed light on how this policy is working, what implementation looks like, and to maintain as much transparency as possible as we move through this, and to learn lessons as we go, acknowledging that these are still kind of first-in-kind policies around the country. And while we're not stepping out alone, there are a number of other states that are exploring similar reference pricing structures. And obviously, we're not the first to do it. It's still relatively new, and we anticipate that we will learn a lot as we go with implementation. Next slide. So as I mentioned, we're in the rulemaking process right now. Our CR 102 actually, the public comment process for the CR 102 actually wrapped up earlier this week with a public hearing on Tuesday, I believe. It will be a new rule codified in Chapter 18240 of our WAC, where we will establish detailed criteria around the reimbursement methodologies and enforcement mechanisms. The proposed rule includes a variety of provisions, some of which are restatements in large part of what exists in statute, but looking at the reference pricing methodology and how we will actually measure and benchmark compliance. Enforcement provisions. So we had the authority in statute to levy fines and other penalties, think about corrective action plans, and what that looks like, appeals procedures for our contractors, et cetera. Some balanced billing protections. So one of the unique aspects of the legislation is that it does include balanced billing protections for out-of-network services. So not only is there a out-of-network hospital reimbursement cap in the legislation, but also some protections such that a hospital that where their reimbursement is capped and is out of network can't go make up any loss of revenue from a consumer. So these are balanced billing protections that kind of parallel some of the Balanced Billing Protection Act protections that exist and are enforced by our Office of Insurance Commissioner, but extend specifically to the PEB and SEB programs, such that we have differential reimbursement caps. And then reporting requirements as well. We recognize that there's a variety of reporting that's necessary in relation to this program, both from our contractors and hospitals to HCA, and then reporting obligations on the part of the agency. So our CR 102, as I mentioned, was published on the 30th. The public hearing was held earlier this week, and those rules should hopefully be effective January 1st of 2026, acknowledging that our contractors need some understanding of what the rules entail for plan development, the plan development cycle that will take place in 2026 for 2027 calendar year, the first year the legislation is effective. Next slide. So I mentioned at the outset, these projections are, I would say, kind of dated where we sit today. We are working through updating them right now and simply don't have those numbers to share just yet. But they kind of largely hold true for economies of scale. What we are projecting is a reduction in enrollee premiums by 2 to 3% relative to if the bill were not in effect. So obviously, this doesn't suggest that we will see 3% reductions in premiums year over year. There are other factors that play into premium development. Those include, utilization levels, costs for other services outside the scope of this legislation, such as prescription drugs. But this is hopefully going to depress that rate growth as a result of the policy being in effect. For the state, because the state pays the employer contribution for PEB and SEB employees in large part. We're anticipating a reduction in expenditures by nearly $200 million over a 4-year period, with growth over time. As I mentioned, as the rest of the marketplace continues to grow at rates that exceed Medicare levels or that exceed inflation, that delta grows over time. And so, again, part of the theory behind this legislation is not just savings, but cost containment. How do we kind of depress that rate growth over time? And then an increase in reimbursement for behavioral health services as well. On the primary care side, as I mentioned, we saw some migration in reimbursement rates up closer to 150% of Medicare in 2024 and into 2025, and anticipate the rate floors for primary care will bring some providers up, but kind of across the board when it comes to averages, tend to see that more as ensuring that rate floor is retained. But in behavioral health, I should say, our reimbursement rates tended to be pretty far below 150% of Medicare for the services that are impacted. And so as we've perfected that modeling, I think that number's actually come up a bit more, and we've thought of which services the provision needs to be applicable to. But again, this kind of significant redistribution of funding towards preventive services, and particularly in the behavioral health space. So with that, obviously, many unknowns to come as we get into implementation, and we continue to work with health carriers, providers, hospital systems about what implementation looks like and how this will play out. We anticipate some additional work outside of the rules and the legislation to set up monitoring efforts so that we can track what's happening with our markets, both within our PEB and SEB program, but also outside of it, acknowledging there's been a lot of discourse about what this could do for shifting costs or implications for other markets. We plan to keep a close eye on what's happening with data analysis over the next couple of years. So once we complete our rulemaking process, we as an agency are turning more towards what that monitoring and oversight looks like, and have a year to kind of set up some of those systems before we get into full implementation in 2027. But just want to say thank you for the opportunity to come chat about it a little bit here. And with that, Mary, Ross, I'm happy to turn it over if there are questions, or back to you if you need to jump to your next agenda item.
Thank you so much. It's so cool to get to see this being implemented and worked out. And just want to say huge thank you to you and your team for guiding this through last year, and then all this work on the rulemaking. So I do see we have one question from Bob. Please go ahead, Bob.
Yeah, thanks, Evan. Thanks, Ross. I had a question about the mechanics of the price cap. Um, I'm a little bit familiar with how that caps on payments work in the context of the Cascade Care initiative. Um, and I'm wondering, in the Senate Bill 5083, is each hospital held to that cap, or do the TPAs, the carriers, have flexibility in terms of meeting the requirements of legislation, and that the average of all their payments are below 200% of Medicare across all of the hospitals? So I'm wondering, like, could they negotiate a higher payment level with a powerful system, but then slam the payment rates down for less powerful, less influential hospitals, so that you get kind of more inequities in pricing as long as the TPA meets that 200%? I'm just wondering how the mechanics work at the TPA level, or whether each hospital has to meet this 200% cap.
Yeah, it will be enforced at the hospital level, so there would not be flexibility to adjust rates kind of in total and across averages, across hospitals. We are planning to implement at the facility level, though. So one kind of nuance is we will be repricing all claims. So any inpatient outpatient services will be repriced to Medicare levels, and assess, we will assess kind of compliance related to that claims adjudication, but enforcement of the provisions will be at the facility level. So that is for a number of reasons, particularly related to kind of how claims come in, outlier claims, and just kind of the granularity of which we can get into enforcement. But that means that there could be some services at a hospital that are reimbursed, let's say, above 200% of Medicare, and others far below 200% of Medicare to get to kind of that equalization of the cap. But it will be enforced at the facility level, so there wouldn't be the ability to adjust across.
Yeah, okay. All right, that's helpful. How then do you go about enforcing compliance? Do you do an audit, or you ask the TPAs to enforce? I just wonder the compliance process itself. I assume there's some sort of auditing process that also backs it up. But
we will do an annual reconciliation. So right now, I think we're working on what the claims run out period will look like at the end of the plan year. We anticipate it's, going to push a couple of months into the following year when we will go through and do that compliance reconciliation. We have contracts here at HCA with contracted actuaries at Milliman who help support that work. And so our finance staff, in conjunction with our contracted actuaries, would go through all of the claims that we have and readjudicate those to Medicare levels using repricers, and then report on compliance. So that reporting would go back before our PEB and SEB boards. Carrier contractors would be notified about their compliance, kind of a transparent process about what compliance looks like. We're modeling some of that reconciliation off of what we have been doing related to the Cascade Select program. So we do have some experience working with Milliman in this instance. So kind of largely the same structure, but again, that would be at the end of the plan year. We'll have some time for claims run out into the beginning of the next plan year, and then we will go through a reconciliation at the agency level to determine if a carrier is compliant with the requirements in the legislation.
And what is the implication for the carrier if they're found not to be in compliance? Is there a penalty? Do they have to pay it back?
Yeah, so in our draft rules, we have contemplated an enforcement structure that kind of includes a couple of components. The first is, and I would say, wouldn't view this as a punitive step, but just kind of part and parcel with the requirement in legislation that reimbursement be capped. We have overpayment reconciliation provisions. So the state would recoup any amounts overpaid. That is a contractual obligation and a legal obligation that we have between us and our carrier partners. So we acknowledge that they are then have contractual requirements in place with hospital systems. And so we are not restricting a carrier's ability to recoup overpayments from the hospital, but we are also not in the middle of that contractual arrangement. So just acknowledging the obligation is on the part of the carrier, but they would have to repay the state for any overpayments. Two, we also have the authority in the rules to establish corrective action plans. So I think that the part we want to emphasize is the goal of this legislation is not at all to be punitive. It is to ensure compliance, to drive cost containment for our consumers. And we do want to commit to working with our delivery system partners to manage implementation. And so part of that includes the opportunity to engage in a corrective action plan so that if we are seeing something coming through in the data that shows there's non-compliance, we can work with the carrier to mitigate that, particularly if it's for some technical reasons or strange contracting regions that we might need to work through to just manage. And then three, we do have the authority, as I mentioned, in statute to establish fines. We are planning to establish fines in our rules. These would be steps that we could take if we saw patterns of non-compliance. So we've actually tied our hands a little bit in the draft rules and acknowledged that we would not give ourselves authority to levy a fine for a single year of non-compliance, but that there would need to be 2 consecutive years at the least of non-compliance with the payment thresholds before we would levy a fine. And again, that is outside of the overpayment reconciliation. So it would be potential kind of penalty provision on top of. So there's the kind of hold harmless for the state with overpayment, so that overpayment reconciliation, so that if a hospital system was overpaid by one of our contractors, that those amounts could be recouped and passed back along to consumers, so they are kept whole. But then there's the ability to try and cure patterns of non-compliance if necessary over time.
Okay. I don't want to take too much time, but I had a question. What happens if individual hospital providers just refuse to treat the state and public employees? Is there any recourse? Are they automatically out of network then and get? But I just wondering if they're refused treatment, your employees and them state and public employees.
If they are an in-network provider,
yes.
Or it's a good question. I think I probably have to get back to you on that.
Sure.
I imagine we have some. I think it lives outside. That kind of lives outside of the specifics of this legislation. But I would imagine we have some other contractual terms and obligations that would be imparted in those instances.
Right. And then we don't have to spend time on this now, but I'm just a little confused at how the payment caps for the children's hospitals. We said they were capped at 150 / 190% of Medicaid RCCs. How that works, and it's probably too complicated to go into for this session, but maybe we can talk offline. I just don't follow how that's enforced or how it's applied.
Sure. Yeah. I think that might be a good conversation outside of this setting, but
sure.
More than happy to engage.
Yeah. Okay. Thanks.
Thank you so much, Bob. And yeah, happy to connect you with Evan. See, Roger has his hand up. Go ahead, Roger.
Thank you. Evan, thank you very much for the excellent presentation. I have a technical question and then maybe a more general one, or actually maybe two. My understanding in the original legislation, and this is back to Bob's, with respect to children's hospitals, Marybridge and Children's, was that they were set at a higher threshold, like it was rather than 200% originally, 210 or whatever, and then dropped down. But in the final legislation, that changed. Is that accurate?
It was I have willful amnesia from January, but I believe we had originally set the payment threshold at 300% of Medicare for children's hospitals, and so that was changed from a Medicare payment threshold to this Medicaid RCC. And again, Medicaid RCC, the easiest way to think about it without getting into the details is it is a percentage of billed
Mhm.
charges.
Right.
So we're saying 150% of 60% of billed charges. So Medicaid RCC is really a percentage that we publish for all hospitals every year. And so you apply billed charges times that percentage times, in this case, 150 or 190% to get to what the reimbursement rate would be. But it is a factor of billed charges. So, functions a little bit differently than contracted reimbursement.
Gotcha. So very quickly, the other technical question would be, and I'm asking this in part with respect to discussions that go on with respect to rural healthcare, and I know that critical access hospitals and sole community hospitals are exempt from, as does Oregon, from these caps. My question is, and this is kind of a technical one, do you know how rural health clinics and FQHCs, which are reimbursed, in Medicare in a different structure, how they're going to be handled in this model? Or if not, might you be able to get back to us with how that's going to be handled?
Yeah, so the hospital reimbursement caps, those payment thresholds in this legislation wouldn't apply to an FQHC or rural health clinic.
Right.
The 150% of Medicare payment floors for primary care and behavioral health
Right.
would. And the
Right.
way those are established, they're on a CPT kind of service code basis. So for any of those CPT codes for which the payment floor is applicable, if it was a service provided at one of those settings, we would have that established payment floor. There may be instances where our carriers are contracted with those providers under different payment mechanisms, be it a cost basis or capitated arrangements, other value-based purchasing arrangements. We would still require that when repriced, all of those services were reimbursed at least at those 150% of Medicare levels. So if the carrier and the provider negotiate a contracted rate above that, certainly that is acceptable and in compliance with the legislation.
Yeah, gotcha. And the only complication is both Medicare and Medicaid pay on an encounter basis, but that's a more technical stuff. So my last question would be, you mentioned going through this exercise of getting some kind of revised, if you will, pricing data and work with through Milliman, and we had opportunity in our FTAC to work with Milliman on looking at pricing structures for our work with benefit designs. My question back is, would it be possible to get some of that more detailed information, maybe back to Mary and Ross, in terms of what, for example, what for UMP, what their payment levels look in comparison to Medicare, maybe on a more granular basis? Is that something that might be available and could be helpful to us?
Yeah, let me take that back and have a conversation with our folks. I think a couple of things. One, we do have some additional financial detail that I know we've shared kind of throughout the past legislative session that we may be able to kind of refresh and bring back before the FTAC. I also know, there are some restrictions that are in place related to kind of public reporting on paid amounts and things through our all payer claims database that are changing in 2026 related to legislation that was passed this past legislative session. So there may be some opportunities forthcoming for us to share more information. But let me talk to Ross and Mary, and we'll get you what we can, because happy to share.
And we're not asking, like, from my own perspective, it's not at a hospital specific data, but it's at a kind of a procedure code level or DRG level, granular, without knowing the particular facility. Thank you.
Okay, great.
Thank you, Roger. Pam, please go ahead.
Yeah. Thank you, Evan. I had the opportunity to work on this legislation, and I just want to note a couple things. One is, I think it was a very important breakthrough, and there was a huge amount of work to get it over the finish line. But a couple things for us is thinking systemically or about a universal system. This gives us a model to kind of watch in terms of how we might approach provider payments, or how we might move incrementally into kind of a more sensible system of provider payments. And then the other thing that I would be really interested in following over time is how do other purchasers and employers respond to this? Are they interested in following suit, or even coming in to join Healthcare Authority in purchasing on behalf of employees?
That's great. Not so much of a response, but just acknowledging. Thank you, Pam, for all of your work and engagement with us throughout legislative session. We appreciate the enthusiasm outside the agency for some of this, and I think we agree, right, where we can see that goes to some of that market monitoring that we want to do. I think that's both data-based, right? How do we kind of look at what's happening with premiums, payment rates, other expenditures outside of our market, but also kind of through engagement with other partners and understanding how there might be downstream impacts, both kind of directly impacting purchasing efforts, but also interest in exploring similar policies elsewhere. So great points.
Thank you, Pam. And last but not least, Eddie, please go ahead.
Sure. Yeah, I had a question. So you mentioned Milliman and you looked at kind of a look back period. So in implementation, would this be done with like the current rate setting cycles, or would this be something that would be done after the fact, like a reconciliation?
Oh, apologies. So our expectation is that these rate caps and floors be applied on a kind of current plan year basis going forward, effective January 1st of 2027. So we know that our contractors are working through contract changes with providers right now and will be into 2026 for that plan year 2027 and beyond. So that is the expectation. In terms of monitoring compliance, we have to do that on a kind of retrospective basis. So we won't have the full plan year claims data to be able to determine if a carrier was compliant with the legislation until a couple of months after the end of that plan year. We will monitor compliance throughout, right? So we'll get snapshots of what that looks like and be able to get some signals as to whether payment levels are kind of sufficiently in line with the payment thresholds in the legislation during the plan year, because we do see claims come in to the agency. We have some unique insights into that data because we are the payer in that instance for PEB and SEB. But to actually enforce the legislation, we need the kind of full plan year review, and that can't occur until after the fact. But this would be in effect in real time, if that makes sense. So applicable to the premiums that a enrollee is paying in 2027.
Okay, so Milliman would essentially take 26 data and then apply these caps before they come up with the rates for 27.
The one point of clarification, we only support establishment of it's a bid rates, but our premiums for the UMP program. So for our self-funded book of business, and that is not through Milliman per se. Milliman supports the agency, but we have a contracted TPA that's working on establishing that. We also have fully insured carrier options in our portfolio for PEB and SEB. So that's Premera and Kaiser Permanente, both offer coverage. They establish their premium rates for their program. So it would be incumbent on our contractors to bring their contracted reimbursement rates in line with the requirements in the legislation. We, in working with Milliman, just do the reconciliation on the back end, the kind of monitoring and compliance.
Okay,
pieces.
thank you.
Yeah.
And thank you. Great question, Eddie. I know, Evan, you have a hard stop at 3, so just wanted to be mindful of that. So I think this will probably be our last question that we have time for. So Roger, please go ahead.
Yeah, very briefly. Evan, if I understand you correctly, in this model, given the fact that something a little over 50% of the folks, in SEB and PEB in total are in UMP, and of course that's a PPO model, or I'm sorry, an ASO model through regions. If I heard you correctly, what you're saying to regions is you're going to pay front end using these Medicare caps for that which regions pays for. So that, as you pointed, that's real time. We're going to pay a hospital at no greater than that 200% level. Am I saying that accurately?
Correct. That is our expectation, is that contracted reimbursement. So the reimbursement rates in contract with providers come down within these thresholds, or up in the case of primary care and behavioral health.
Thank you.
Yep.
And that looks like all of our questions. Again, Evan, thank you so much. You do such an excellent job of making this complicated information seem understandable. So just really appreciate your work, and thank you for coming to join us today.
Yeah, appreciate it. Take care.
And next up, we have Mary, who's going to be giving a work plan update. So take it away, Mary.
All right. Thank you. Thank you, Evan. Thanks, Ross. We can go to the next slide. We can go to the next one. This is kind of a quick work plan update. This is the tracker that we've been using throughout this year. I hope what I'm about to say answers Maureen's questions from the public comment. In the last two commission meetings, sorry, reaching back into the past, oh no, I'm going to get the dates wrong. I'm not even going to try with the dates. In each of the last two, the commission approved one of the straw proposals. So they approved the eligibility straw proposal and they approved the benefits and services straw proposal. Both of those were incorporated into the 2025 annual report, which you'll see on this also has turned green because that has been submitted. So those two straw proposals for those two topics were approved, folded into the annual report. They're mentioned within the text, and then they are folded in as appendices, the actual text of the straw proposal. So that's where you can find them. So the exciting news, the ledger report was submitted last week, the 30th or the 31st. It was due November 1st. So we got it in. We talked about the work that was done. And on today's agenda, we're going to be we'll continue to talk about provider participation and reimbursement. And you can see over on the left, that is still the light orange color. So that's where we stand, working our way through this. And the sideways text is a reminder that the cost containment is being woven throughout. And yes, thank you, Allie, for posting the link to the annual report. Very exciting. It's online in the same place you find all the other information about the commission and FTAC. And the next slide. Whoops. Here we go. Looking ahead to our workflow for 2026. And this probably should say proposed workflow. I probably should have put a draft watermark on this a little more strongly than I did, or put one in there. For much of 2025, topics went back and forth. They went from FTAC to the commission to FTAC to the commission. And we set our sights on getting through a couple of the core elements of the universal design. We got through two of the three. We're running out of time in 2025, so I think we're going to land on having gotten through two of the three that we had set our sights on. But what we're thinking about is next year proposing parallel work streams, not so much the back and forth, but FTAC and the commission working in parallel. So if we can go to the next slide, this slide has a whole bunch of information on it to walk through and to think about. So that's the same left column we just saw 2 slides ago. And provider participation and reimbursement, which is orange, stays with FTAC. This is design element. You come up with the recommendation to the commission, including guiding principles in early 2026. Then we get to financing, which also goes to FTAC. And that is some work in 2026. That is probably a likely use of the proviso funding that we have for analysis, the Office of Insurance Commission proviso funding. And then we are thinking perhaps after financing, it is when this committee sunsets. And the next 3, enrollment, infrastructure, and governance, could be taken on by an operations committee. We were thinking if we stand up an operations committee, after financing wraps up, then operations takes on these other 3 topics. And again, this is all proposed. We're still figuring this out internally, still need to discuss things with the commission, but this is the idea that we have floated. And the next slide talks about the proposed approach for the commission. So we've talked about FTAC taking on some of the design elements, other design elements being given to operations committee later in the year, so that the commission focuses more on interim solutions. And they would be prioritizing projects that could serve as pilots for the eventual universal design elements. They could be pilots. That's as it says, they also could be things that are addressing the moment. They're addressing what we are facing in 2026 with a lot of people's coverage, availability of coverage, and cost of coverage. And the way we envision that work is they will draw on the work of other boards and programs, the Rural Health Transformation Program, the Healthcare Cost Transparency Board, Prescription Drug Affordability Board. Did I just get that name right? PDAB? I'm not sure.
You did.
Yay, my apologies, thanks. And develop recommendations to the legislature and incorporate that universal design. And complete aside, since this slide mentions Rural Health Transformation Program, Washington's application was submitted. I think Evan mentioned this earlier this week. So if you go online, there is a Rural Health Transformation Program page, and you can see what Washington has submitted. I'm not quite sure CMS's schedule for a response. I think it's December 31st. Again, it'll all be there if you wind up on that page. And so the next slide. This is a quick update. I'm jumping around with this work plan section. The Healthcare Cost Transparency Board met on October 23rd, and that's a link to the meeting. The link will work in your packet. And Senator June Robinson presented to the board about the corporate practice of medicine. There was a bill in the last session, not sure what the plan is for the coming session, but she did talk about it and talk about the reasons for it. I don't know if any of you were able to tune in. If these links don't work, send us an email and we will send you a link to the timestamp so you can hear what she had to say. And then also a researcher from Brown University presented on recent enhancements to Oregon's corporate practice of medicine law. And I think that's the end of my slides. Next slide. Oh, I'm wrong. Another annual report. The draft annual report of the Cost Board is available for review and comment. And there will be a public hearing on that 2 weeks from now, 2 weeks from today at 2 p.m. And I think now I've come to the end of my slides. Yeah, I did. Does anyone have any questions? I touched on a whole bunch of topics. Roger.
Yes, Mary. So I have a question. Let me just repeat again. What I'm understanding is that for this coming, we're going to be gazing today and next, this coming year, that FTAC will again focus on the work around provider participation and financing, and that's the focus, if the work plan for us. And just repeat again that the Universal Healthcare Commission is going to deal with quote unquote more transitional issues. I think my question would be is one of, if you will, of expectations. And so my question is, with the work that FTAC is doing, is it anticipated in the area of both the reimbursement and the one on financing, that, if you will, straw proposals, to use a term of the day, a term of art, would be submitted to the commission, and there would be an interaction thereafter between the commission and FTAC to, if you will, finalize those proposals? Or this is A, or is it A and B? And B would be, with those proposals comes, lack of better words, financial analysis. And the distinction I'm struggling with here a bit is we did, some work wrestling around, partly at least, with the benefit design. And I would make a comment that, in my view, there's still work to be done in the area, because we've defined the benefits, but not so much the issue on point of service cost sharing, separate discussion. But we had the opportunity to draw upon, expertise and technical support from Milliman. So is it envisioned that as we continue with our work in these two areas, that is it the expectation, of the commission, that in addition to a document, that they would see some fiscal analysis or analytic analysis that's associated with it?
Okay, I'm going to actually go back to the very, very beginning, and I just want to clarify, this is the proposed way to split it up. I mean, when we talk about the commission doing the interim solutions, I just don't want to, what you recapped was correct. I just don't want to present it as set in stone, because it's not set in stone.
Okay.
The second half, I think your question kind of boils down to, how deep do the recommendations go? You know, is it a financing recommendation or does it have nitty-gritty financial analysis attached to it? Is that kind of what you're asking?
Yes. I'm going to add one other thing, and maybe part of the end of this is something that Vicky and others can address. I'm going to stay with this just a little further. In the end, when the commission's work is through, do they anticipate presenting to the legislature a model with a option or multiple options that have analysis around them? The example I would use is the Universal Healthcare Work Group that essentially did that in their report to the legislature. And is that sort of a deliverable that the commission at the end of the day is anticipating? Or is it just, you know, here's kind of an annual report with our thinking, and we'll continue to annually report you as things go forward? I don't expect you to be able to answer that, Mary, but I think that's one that, from my own perspective, would be very helpful to get further, you know, clarification on expectations from the commission, because that, I think, is going to guide the level of work and expectations we should bring to our work.
Yeah, absolutely. And you're right. I really don't have a solid answer to that at the moment. And that is a question to take to the commission, and that is a question to guide the work. So thank you. I appreciate your bringing that up. And that is something, as I said, as we formulate these plans going forward, we will be figuring that out. And I don't know if Vicky is on the line right now. I know she's presenting in a bit. I don't see her here. So is she here?
I'm here.
Oh, can I put you on the spot?
Yeah, no, that is a really great question, Roger. I think, you know, we dove into like the nitty gritty of figuring things out and really have had a big focus on incremental, you know, incremental things that can make things better. But I do hope that we can, you know, when we get all the pieces together, get to a plan. But I think in the meantime, we're also trying to scoot that way incrementally. Does that make sense? Like I really appreciated Evan's presentation on the reference point pricing, because I think that's something we could look at. And I think that was your question too, about the Milliman reporting, is like bringing that all together. So, you know, I don't think of things in a straight linear way, and this is in no way a straight linear project that we're doing here. It's more like a spider's web, pulling in the things that we can until we get what we need. Does that make sense? And maybe that's foreign to some other people, but I mean, I know that's how we think in Indian country. So did I answer your question, Roger?
Well, yes and no. I think the challenge we face, and I'm sorry, I don't mean to take our time on so much on this, but what we face is trying to get as much clarity, and I understand it's a challenge, from the commission on what they need. I mean, I'll be crass. We can sit there and pontificate on various options and say there's a little of this, a little of that. But it seemed to me, at least, where there was some merit back to the commission, and we had the opportunity, of course, the resources to do it, is at least have Milliman go through an exercise with it and say, well, here's kind of what 3 different benefit designs look like, and estimates about the magnitude of the cost.
Yep.
And that analytic analysis, I think, at the end of the day, helped guide the commission to say, you know, and this is an affirmative statement they made, is our basic benefit design for the Universal Healthcare Commission is UMP Classic plus dental, and we based that in part on the analytic work that FTAC and Milliman were able to provide. That to me is different than us, you know, saying, well, you can consider this and consider that, and here's a bunch of sort of options without, I keep using the word analytic, but the modeling rigor that I think the commission personally needs. And I'm just trying to get a sense of what you would hope the commission's expectations, because that's going to come back and guide our work, if I'm making sense.
Yeah, I think we think differently too, and I think, and I know that, but Like more like peeling the onion until we get to the part. So we're throwing out the things that don't make sense. So we've kind of put aside Medicaid benefits and Cascade Care, right? And we're focused on UMP now. And now, I think for the next year, what we're looking at is how do we pull in the work that the state's already doing? I think Mary mentioned this because we have the Healthcare Cost Transparency Board, which we do get a lot of information from, but there's the primary care certification transformation, the thing I always get the wrong name. And there's these other things that will help with getting uniform payments to providers, especially primary care providers, and thinking about what Evan was talking about with the reference-based pricing, improving payments to primary care providers. And this is another piece that helps support that primary care piece too. So I know it's really hard for people not to have on this date, we're going to be done with this, because as we find things out, we need to be able to investigate them more and see if they are going to help this, or, what we're working on, or not help it. So, yes, in the beginning, the bill had a timeline of being done by 2026, and I think we've really pushed, and we've been following the work plan from the work group and trying to get there. We did not foresee some of the things that are going on, right now. So we have to take those things into consideration. But I think the ability to have those incremental improvements that address things that are happening right now are really important, but keep moving the work forward. And that's why the parallel course for the next year is so that we can kind of ramp it up and work more quickly. But I do hear you that you feel that we need to be more clear in what we need from the FTAC, right? Okay. We will talk about that at the next commission meeting. All right, Mary Ross?
Yep.
Okay.
Thank you, Vicki. And Pam, did you have a question? Oh, you're on mute.
Thank you for noting that. This is similar to what Roger was raising, which is that our purpose as a advisory committee is to give advice, and it's to give advice to the commission, which should be driving the whole picture. And I think that what we're missing is kind of that driver. And so as we put together the pieces of universal, like a universal system, they are indeed pieces. They are not. It's not necessarily going to look like a universal system. It's going to look like various pieces. Vicki was kind of alluding to that as well, kind of just acknowledging that instead of like kind of a systematic plan of a universal system is how you might typically go about it. We've instead done kind of pieces as asked by the commission. So I think in terms of what I'm asking of maybe from the staff or from Vicki is just as you go into this, if someone will just maybe go up to 20,000 feet and take a look at this, like where is this going? What do you want the end product of this to be? If you want to sunset this committee sometime next year, do you want us to have handed off a report? That I think that what we would hand off is not something that could be operationalized, but I guess it could go to an operations committee that could think about how you might put it together and operationalize it. But I think that, it's making me want to sit down and read our report again and sort of see what we have there, what we've accomplished. I know we've got lots of pieces, but we don't have the whole picture. And I've thought of the commission as responsible for the whole picture. So I'm just kind of rambling a bit here, but I kind of want to understand where that lives and how we get there.
And just one, I really appreciate the comment, Pam. One point of clarification. So you're talking about wanting to know kind of what the end product is specifically for FTAC or for the commission?
If we were consultants, you'd say, well, you wouldn't necessarily have to say this is the end product, but what do you want the deliverable to be?
Okay. And that's speaking specifically to FTAC as as there's a suggestion that FTAC may be sunset, acknowledging this is all still a work in progress. What would that final deliverable be for FTAC?
Yeah.
Okay. What a astute, excellent question. Thank you, Pam.
Thanks, Pam. I don't think we have any other questions. So Ross, it's back to you, I think.
Thank you, Mary, and thank you everyone for those questions. Those are great in that we can work on those and bring some of those to the commission, and I think we can answer some of those. So thank you. Next up, we're going to be hearing from Chair Vicki Lowe with an update on the commission's October meeting. So I'll hand it off to you, Vicki. Thank you.
Thank you, Ross. Again, Vicki Lowe, Chair of the Universal Healthcare Commission. And so we still do not have an FTAC lead. And I think I heard Ross at the beginning of the meeting, putting that out there for anybody who's interested. Please let us know if you're interested. So I'm going to give the commission update today. The commission met last month and covered a number of topics, including the 1333 Interstate Compacts, OIC proviso funding, and provider reimbursement participation. And I'm reading off my computer because I'm not at home, so I won't be able to see if anybody raises their hand, so help me out, please. Let's see. We received several public comments at the October meeting. Some highlights that may have been interest to the FTAC are support for consolidated purchasing efforts for public and school employees and limitations on corporate practices of healthcare. We just heard about both of those. Requests for the commission to work with the legislature and healthcare authority on healthcare bills, and support for single payer healthcare that includes strong price controls and administrative simplification. Next slide. We also confirmed our work group for Connecting with Oregon. Commission members Joan Altman from Washington State Health Benefit Exchange, Jane Beyer from the Office of the Insurance Commissioner, and Nicole Gomez from the Washington Federation of State Employees will be representing the commission. Healthcare authority staff are in the process of scheduling a meeting with counterparts in Oregon. At this time, there's no current plan to pursue a Section 1333 Interstate Compact. The work group will keep the commission informed as members learn more about it and explore other innovative options in conversations with Oregon. OIC, as you're aware, the Office of the Insurance Commissioner provided funding for a future study related to the design of universal health care systems and to the Healthcare Authority. The Healthcare Authority and the Office of the Insurance Commissioner staff are working together to determine the next steps. The Commission has not yet tackled this topic. We expect more to come soon and seek guidance from the FTAC as we move forward. And then provider reimbursements, the commission appreciated the update from FTAC September meeting and the robust discussion on provider reimbursement and participation that you all had. Several commission members offered feedback, including a request to incorporate findings from the Milliman analysis and any relevant studies related to Senate Bill 5083 into the straw poll. And that was the bill we just heard about from Evan. Members also requested the guiding principle for provider reimbursement participation, including stakeholder perspectives such as rural considerations, and the administrative simplification be incorporated into the principles as well. And then more on provider reimbursement. Commission members also asked whether the payment structure, for example, direct to provider payments or managed care, were in scope for this discussion. Lastly, members requested the straw proposal include consideration of the work of the other commissions, boards, and task force that are working on this topic in Washington State. So that is the update from the Universal Health Commission. Any questions or comments? Roger? Oh, I think you're muted.
Yeah, thanks, Vicki. Again, I'll try to be brief. One, I applaud the statement in the PowerPoint about with respect to the involvement in the 1333 waiver. And my cautionary note would be on that is to say, to a degree, my concern is that it strikes me a little bit as being out of scope of our own work. And given the limited amount of resources that we stay within our
Mhm.
within our boundaries. I'll talk later. I think it's one of the things we're going to be talking about, but we'll get back to you on this issue of the relationship between, lack of better words, what I call delivery systems, between the issues of the delivery system being a carrier-based, ASO, fee-for-service, et cetera.
Mhm.
Where your bullets there. I'll just say I think we're going to have hopefully some good conversations on that as it relates to provider reimbursement, and hopefully that'll provide maybe some clarification and feedback to the commission on what I do know is a very gnatty issue. A major, and I fully understand that one, and so hopefully we'll provide some effort in that area.
All right. Thank you, Roger. Yeah, the 1333 waiver idea, the first thing we were thinking is who's going to do this work, because there's not staff at the healthcare authority. So yeah, agreed.
Well, and I'll say this very briefly. I'll do respect. It's not in the healthcare authority's domain.
Yeah.
This isn't.
But the commission is like all of the agencies and
I know
other people trying to figure this out. So
is rural health, right? We have another group over there. Sorry.
Any other questions? I also have to go to another meeting. I'm sorry, but I've enjoyed this conversation and the presentations. Thanks for letting me be here.
Thank you so much, Vicki, for all your work and for joining us here today. And thank you and good luck at your next meeting. Let's see if I am reading the agenda correctly. I believe next we're going to hear from Allie and Pam for a discussion on what FTAC considers in and out of scope in the provider reimbursement anticipation straw proposal.
Thanks, Ross. That's right. And we'll have a
Okay.
break after this. So, but hi, everyone. So staff just wanted to take a moment to step back and have a scoping discussion for provider reimbursement and participation. You all had a robust discussion at the September FTAC meeting where we touched on reference-based pricing, hospital global budgets, some key pieces to consider when developing provider reimbursement models, and more. And then as you just heard from Chair Lowe, the commission had some additional feedback. So if you could go to the next slide, Audrey. Thank you. So before we dig in further into those details, staff wanted to step back and do a level set together about what is in and out of scope for this topic. And Pam has graciously agreed to help me facilitate this discussion. So thank you, Pam. And before we get started on that, I just wanted to share the objectives for today, which are to clarify which elements of provider reimbursement and participation belong in the initial straw proposal, identify which areas are out of scope or premature for inclusion, and then discuss next steps and provide direction for drafting the straw proposal. And next slide. So to kick us off, staff put together some suggested language for framing what we might mean by in scope and out of scope for purposes of this discussion. So this is for consideration by you all before we dig into the actual elements that are in and out of scope. And these are just meant to provide some high-level boundaries to help us kind of have the conversation, and they're certainly open for edits. We thought of in scope as potentially being things like high-level concepts, principles, and transitional frameworks needed to explain how provider reimbursement and participation will function under a universal system. And then the suggested framing we have for out of scope are those technical details and specific implementation steps or design elements that could be developed later or handled by another group. So this is really just some suggested framing to help us define what we mean by in scope and out of scope for this discussion. So I'll kind of open up the floor to you all, hand the mic over to Pam just to kick us off for this first part of the discussion on whether this language feels right with the group in terms of high-level framing for deciding what is in and out of scope, or if there's questions about what it is we're doing right now.
Yeah.
Thanks, Pam.
Yeah, thank you, Allie. And I will kind of help move us along here. But I think that what we want to be doing is developing kind of the bones and the framework for what we would fill in for, the provider for provider payments system. And this would go to the commission and then come back to us to do some filling in early in the year when we have our meeting in January, if that helps kind of get a sense of the timeline that we're working on. So first of all, I want to ask if there are any comments about the whole, what Allie talked us through about how we think about what's in scope, what's out of scope. And obviously we're looking for the major, framing pieces, and the out of scope is where you would see that would be in the weeds. It would be the technical details. And many of those things not necessarily are they're obviously relevant to the system, but they're not what we need to get into now. Those are things that you would do later. So are there any comments or concerns about this approach? If not, we can go to in scope and have you take a look at that list, which is the next slide. And this is staff prepared this for us. So this is, think of this as a straw proposal to us to discuss. And the in-scope areas would be the guiding principles, hospital payment approach, physician and other provider reimbursement framework, provider participation incentives, in alignment with ongoing work, with acknowledgement that these are all huge things to understand and discuss and fill in. And then, so looking at this list and the description and taking a minute to kind of get your brain around it, is there anything that's missing for you? I'm just seeing it in Roger's hand. Roger.
Yeah, and maybe we'll get further discussion on this, on what's in scope and what is out of scope. I'm focusing on this one about administrator simplification. And, this issue continues to come up. We always use the example of we should simplify prior authorization. We should simplify billing standards, et cetera, all of which I would argue are absolutely correct. But if we're talking about the macro system here for a moment, the big picture, many of these issues are addressed in the very nature of the system we're constructing. So let me use a real world example, which I wrestle with. So administrative simplification, there's ongoing discussions about prior authorization, right? We need to standardize it, standard forms, et cetera, which I completely agree with, and the criterion for what you do prior authorization. But if we're talking about a single payer unified system, by definition, that's going to occur, right? The same thing occurs in, we should have standardized billing. Actually, the forms now are fairly standardized in the protocol anyway through what CMS and Medicare has done. But even further than that, and by the very nature of the system, that issue is addressed. So I guess when our discussions, when we're talking about provider reimbursement, I get somewhat uncomfortable of wandering into the area of administrative simplification for our work, given the fact that the very nature of the system will accomplish that, in my opinion.
Yeah, so in a way, Roger, I would suggest that possibly that could be addressed under guiding principles.
Okay, good idea.
Are there other comments about what's in scope? Okay, I think we can go to out of scope. And again, this is what we would defer to later stage of system design. So it's the actual rate setting methodology, operational timelines, administrative or technical systems, e.g., who sets and pays provider rates, claims processing, and data reporting. And is there anything that anyone would want to call out as being out of scope for the discussion? Roger. And you're on mute, which I can relate to. I do that all the time.
My apologies. Let me see if I can say this in a clear example. Bob has led us through a long and really good discussions on hospital global budgeting. And we see that as a potential, if you will, model design for the new system. Now, my question to myself is, well, let's have a good conversation about it and say, well, that's something that should be in the hopper for consideration, I guess. I mean, that's one thing to say this. In an ideal world, and I know we're not in the ideal world, but we would have an ability to say, well, we have a model in place, which we don't have now, and it's based on basic set of assumptions. And then we talk about global budgeting. We incorporate that into this model design, and it gives a much richer analysis about what the implications and impact of global budgeting would be. I'm just trying to use that as an example. There's countless examples along this way. And what I'm hearing using global budgeting as the example is that we at this juncture aren't proposing to go down that pathway. I'm trying to find some borders here, and I guess I'm using global budgeting as the example. I'm not making sense anyway.
I don't think it's easy to find the borders. I think that's why I think the principles discussion is going to be so important.
Okay, because one last thing, I'll just give another example here briefly. I'm sorry to do this. It'd be worthwhile for us to see it. A couple of years ago, the legislature directed OIC to look at a series of potential affordability options. And they did an initial analysis with HMA that said, here's 11 areas to look at. And they came back and said, we're going to look at 5 of those. Global budgeting was one of those, reference-based pricing, the other ones that were in there. Medical loss ratio is another example. And they came back and did some analytic analysis and says, here's what we guesstimate the impact of those 5 options, which I think was very helpful to guide the legislature's deliberations. I'm hearing us say we're not going to probably be in the ability, and I know we don't have the resources to do that now, so it's a rhetorical question, but the ability to do that level of analysis to provide what is going to be needed guidance to the commission. Is that a fair example or statement? Sorry.
Could you restate it, Roger?
Yeah.
Just the end of it.
Yeah,
Well,
I got lost too.
Well, so we're going to be talking about reimbursement options, okay? And I'm trying to do an analogy here. The legislature directed OIC to say, think about affordability. A lot of that was on reimbursement of various types. They identified 10 of those. They selected the 10-5, and then they proceeded to do some fairly decent analytic analysis to try to cost out in these orders of magnitude what each of those look like in terms of impact on the aggregate system. So that the legislature had a basis to look at these options and begin to make some decisions. Quite frankly, the one on reference-based pricing led to a lot of the ability of this legislation to get enacted that the Healthcare Authority did, because the legislature was keenly aware of that as a real viable model. My point is, I don't want to get lost in this, I'm sorry. That level of analysis was very helpful to the legislature. I'm assuming that, in theory, that level of analysis in this area of provider reimbursement would be of much use to our commission. Now, here's my rhetorical comment, but I can appreciate that it's going to require some modeling and some analysis that, we don't well, maybe we do that 250,000, but we don't have listed on the table today. So I'm trying to get myself straightened out about where we draw the line on these things.
Yeah. I think that we're not ready to answer that question.
Fine, okay.
I
Okay.
think that because we're just really we're like
Sure.
trying to make lists
Understood.
like what's in scope, what's out of scope, what are our principles, and then I think if we come back, every single one of these dots is huge, and as we start to kind of zero in on how we want to think about those, it may become apparent that we need some outside analysis and help, and that would be up to staff to determine if that's available or not. But I think we're not ready for that.
Well, you kind of hear my dilemma as I go through each of these.
Well, you tend to help us look down the road and think about what's coming. And sometimes we know, and sometimes we can't be sure. We won't know till we get there.
Fair enough. Thank you.
And Pam and Allie, please correct me, but I don't think that we're saying that any of these bullet points currently on the screen won't be worked on at some point. Just, does that fit better in a different part of the work plan further down the road? And, we don't want to, this is such a broad topic to your point, Roger, just trying to find some lanes to kind of drive this conversation. So just
Yeah.
yeah. Okay. Sorry if I just wanted to reiterate. I think that these topics will be discussed later in different contexts. We're just trying to scope this so we can have productive, efficient conversation.
Right. So if we just try to put those thoughts out of your mind and just look at this, which I know is not easy, but just look at the scope and is in and out of scope looking appropriate. I'd invite other people on the committee to weigh in. I don't know. I think Christine, you have some experience with these topics, whether or not this looks right to you, or Eddie, looks like your hand is up.
So I just wanted on the part where it says, detailing rate setting methodology, obviously that's a big one. But the work that we currently have from Milliman and is that run its course? Because I thought we would be answering more questions with regard to that. And that is providing some type of basis for the numbers, which I thought was a major component of our delivery.
Mm-hmm.
So saying that the detailed, of course, being set aside, but the current work that we have done, and then it was going to, I thought at one point turn into an additional set of work. So do you have any thoughts on that?
I'd ask staff if
Yeah, I can jump in. There's the Milliman work that was completed earlier in this year, that you all have seen, and thank you, Eddie. You were part of the work group that helped make that happen. And then in the time since then, there has been proviso money from the Office of the Insurance Commissioner, and I'm not going to come up with the exact language. And the language is something like continued analysis, continued financial analysis. I can look it up during the break if you need to see it. But it is yet to be determined, and that's $250,000 during the biennium. It is yet to be determined how that money will be spent. So in theory, it could be a continuation of the questions already asked, or it could be a different set of questions. We don't know that yet. I don't know if that answers your question.
Okay, yeah, I just was wondering, moving away from more of the numbers analysis and going more into guiding principles. So,
okay.
Yeah.
And I just want to say too, sorry, my internet is unstable. It is very rainy here in Olympia. But one item of feedback we got from the commission in October is that they wanted findings from the Milliman report that had been done already to be incorporated into the provider reimbursement and participation design work we are doing. So that last bullet there is kind of doing a lot of heavy lifting, coordinate with boards and commissions, but also incorporate relevant findings from the Milliman analysis, bring in anything relevant from the SB 5083 analyses that were done. But yeah, I think to Mary's point about future work, that's still TBD.
Thank you.
Thank you, Allie.
That's really helpful.
Yeah. Thanks.
Okay. Does anyone else want to comment on the kind of in scope, out of scope approach or lists? Should I assume that it looks like a viable approach? I'm looking at faces. I'm not seeing anything. So I think we're okay on this. Let's go to the next slide, which is next. Okay, so I think we've agreed upon these lists, very quietly agreed upon them. And then which of these in-scope topics needs additional research or external consultation? I feel like we need help on all of these. I'm interested in what other people think, but these are big topics, and I know there's some excellent resources. I think that even in some of the consumer presentations, I think they kind of link to some of the sites where they're, websites where there's just extensive research and policy support that has gone on in these topics. So I think help would be great for the group. I don't know if anyone would like to kind of raise their hand and talk about where they'd want more information or have suggestions about that. Again, looking at Christine or Matthew, Bob.
Should we go back to the list of in scope? Audrey, if you go back a couple, there we go. That might jar people's minds a bit.
Well, I think, Mary, we're all going to work on guiding principles, correct?
Yep, that's what's after the break.
Okay, so I think that in some ways that'll also help us get to where we need more help. But I think that these 4 areas that are under guiding principles, it would be helpful probably to have some more information and background.
Okay. And Roger, did you have a comment? Oh, you're muted.
Excuse me, to the break. I would like to have a discussion further about some items, in my opinion, we need to discuss about what is out of scope. Now, now or after the break is fine. I feel compelled to at least have that conversation. So,
are you do you want to raise some concerns about what's out of scope to move them to the different list?
No, there's, I guess, 2 areas that I would want to make statements, or at least advice back, that should be treated as out of scope for this immediate exercise. So should I just go ahead and do that? It's a good time to.
Yes.
Okay, all right. Number 1, and I saw it was kind of a comment I had back with Vicky, and I'm going to call the term delivery system, because that's where the term should be. And it's around the issue of, and what I mean by delivery system is not what you pay providers, but is it through a carrier-based system? The other extreme on that is what Medicaid still does, and in some areas, in its fee-for-service system, straight fee-for-service system, or that, like Connecticut does in its Medicaid program, or UMP does for it goes through an ASO type model to administer the payment system on behalf of the payer. And that topic is huge, and it deserves its own separate deliberation. And the reason I say that is because any of the reimbursement systems we're going to be talking about can be handled through each of those 3 types of delivery systems. But the whole issue around delivery systems is a critical one that needs to be treated as a standalone one. And I don't know if it was, looking through these things when they were talked about, look in the areas that people can be dealing with. One was infrastructure. So I don't know if by infrastructure people were talking about, do they mean delivery system or not? Is that where that conversation comes in? But let me try it one more time. It is a critical issue. It's a huge, huge issue. It needs to be treated as its own topic. It has huge implications outside of how you pay providers. So I'm making a request that be so noted. The other one I'll come back on to is this issue again around administrative simplification. I would again argue that, again, we're asked to be looking at the macro system here, that many of the discussion pieces that come out around administrative simplification, by definition, would be addressed in a unified, single finance, unified system. So that those items, in my humble opinion, should not be part of this discussion. I can see them drifting into it. I mean, we see this all the time. The commission says, well, we need to simplify things, right? I get that, but that's not what we're talking about in this arena.
Mm-hmm.
And so that it also needs to be in its own separate bucket.
Okay.
See a pregnant pause.
Well, if I'm hearing you correctly, Roger, then for the purposes of provider reimbursement, are you agreeing that the administrative or technical systems should remain out of scope for this topic?
I want to be a little more specific. It's around delivery system. Administrative means many things.
Okay.
I want to try to be real specific on this one. This is a huge issue, folks. We've been through this many years on this whole issue. I'm imploring us to keep it. It's a critical issue. It needs to have its own meaningful discussion. I believe our group can provide some insight into it, but it's a separate issue.
I don't know if this is helpful, but again, I think that there are a lot of ways to set up provider payments, and the kind of system you have, whether it's a fee-for-service system, it's carriers, there's a lot of ways to make that simpler, but the decisions that you make upstream will determine what kind of administrative simplification conversation you have downstream. So I think that there's a way that if we look at the in-scope issues, that I think we are front loading this conversation in a way that you're recommending. And as we get into them, you're not comfortable, we can kind of back up and talk about those assumptions.
Okay. Well, and the last thing, I'll leave this alone. I think it's something that the commission itself skirts around. And I guess I would hope that somehow that we can share with them some feedback that this is a critical issue that, I'll just repeat again, deserves its own bubble, if you will, of topic. And that we're not, I would implore us not going to deal with that issue at this time.
Yeah.
They think otherwise, that's fine, because that would re-give our scope, but it's a whole, as we know, a whole bailiwick unto itself. Blank looks. Okay.
Okay.
Thank you.
Can we look at the next slide again, Allie? So.
Sorry, could I ask one follow-up question, Roger, on the discussion about payers in delivery system? Because Because I imagine some discussion of payers is going to come up in the provider reimbursement discussion. It's the aspect of the delivery system of the payment specifically that you're concerned about bleeding into this discussion, Roger.
I think there's a feeling, how do I try to say? It's the administration of the program. Okay, let me just try it this way. I don't know how to try to say more clearly. And you can administer it in, I laid out 3 models, and there's subsets to each of those models. And I'll repeat again that in any of those 3 models, provider reimbursement is a critical component, obviously, and all of our discussions, if you use global budget, if you use any of these other things, can fit into any one of those delivery systems. But that notion about carriers or whatever needs to be stripped away from this discussion, in my opinion, and it deserves a standalone discussion and development by the commission, and maybe FTAC's involvement with it. I can't say it any more simply than that. I'm sorry.
No, I guess I was just kind of looking at
Am I
the work
talking to you?
plan and seeing where this might fit. And it seems like maybe how you're viewing the delivery system may fit in the infrastructure conversation a little bit further down the road or something. So I was just trying to
Sure,
see
sure,
where it would fit later
sure,
in our
sure. That would be,
project.
yeah.
Okay.
Yeah, because one more last time on this issue came up, and I saw it again when they're talking about governance. And Jane did a nice job of trying to, with the commission, because we got kind of in a circle on this. And she said, as she thought about it, governance is who sits on top of this system? What's the governing body that's going to run this thing, right? That's governance. And then how it's administered, who's doing the work, if you will, is a separate component under governance, in my opinion. And that's where I think you do get into this discussion about delivery systems. So that fits under infrastructure, that's fine. But I think it needs to be called out in our work back to the commission, so these 2 things don't get tied together at this time. Because I see that discussion coming out in their discussions.
Yeah.
You hear it. So, okay.
Thank you, Roger.
Yeah.
Yeah, I think that we'll get into some of those things as we get deeper in this discussion. I think some of the questions that Roger's raising will reappear. Like, do you have a fee for service system? Do you have everybody on the same payment model? Do you only have some of the services on the same payment model? Those are all decisions that you drive, and you usually drive them more from the top down than from the bottom up. And we don't have some of that top down direction. So therefore, I think what we do is present options until those decisions are made, which is what we've done so far. Actually, that has been our modus operandi. Okay. There's a question on the bottom, which is, who is interested in working with staff on the outline? Any volunteers?
After we made this so clear for you all, I'm sure
I know.
everyone's going to be itching to join us on this project.
Roger's volunteering. I think it will be more clear as we do the principles. That's my belief, or my faith in that.
Thanks, Roger.
Yeah.
It is a little chicken and the egg conundrum. And
Yes.
so thank you. I really appreciate it. We've been talking about this internally and trying to figure out how to scope it. So really appreciate this conversation. And thank you, Pam.
Yeah, I think the scoping is good. I think one of the reasons we were not hearing from everybody is because they look at the list and it seems logical. So I think staff should feel comfortable with what they prepared. Okay, back to either Ross or Mary or Allie. I don't know which of you.
Whoever will say it's time for a break.
It's time for a break, yeah. I think, are we taking a 10-minute break?
Yes.
Yeah.
Okay.
So see folks back here at 4:05.
All
Sounds
right.
good.
Great.
Thank you,
Thank you all.
Pam. Thank you,
Thank you,
everyone.
Pam. Thanks, everybody.
Thank-
We'll be back.
Holy smokes. Is it coming down for you, Mary?
It was a little bit ago. I think it's let up,
Oh, okay.
but
It
it was
is.
crazy. We had lightning last night. We had thunder and
Oh, wow.
lightning. Yeah, a couple claps of thunder.
Ross, you're an Olympia, aren't you?
Yeah. Are you in
Yeah.
Olympia, Roger?
Oh yeah, I'm sitting from my house and I just heard, oh my goodness gracious,
Mhm.
it's raining.
It is. It's raining. I
It's
know.
raining.
Fingers crossed we don't lose power.
Yeah.
Mhm.
No.
Although I suppose if someone wanted to leave the meeting, you could just leave and be like, "Oh, sorry, I lost power."
Don't give any ideas,
Don't give any
Mary.
ideas.
That sounds like a trick I would pull in college.
Yeah.
Hey guys, under full disclosure, at the very end, could we have a 1 minute conversation on just to reconfirm an issue that Eddie raised about our previous benefit design work?
Do you want to address it when
Sure. I mean,
officially back? I don't know, Ross, how you want to do
yeah.
it.
Well, yeah. Just fine. I see Eddie's here.
Well, I think we should wait until we're officially back
So we're
from break
officially back.
so that
Okay,
other
yep.
folks are. But yeah,
Right.
Okay. I'll be
But
brief then. At the end of the
before
day.
our last item.
Yep. Okay. I'm not sure I want to because he's no longer in that fancy house of his. Where's your backdrop, Eddie?
Yeah, that's right. I think I got downgraded when
Yeah.
Zoom updated.
It's
That's
beautiful.
what happens with
Beautiful.
technology.
Hey, I have a question for everybody. This is an off the record one, but what would you do with $1 billion? Mind-boggling, isn't it?
is this in terms of like establishing a universal system or just
No,
you
this
know,
is
Roger
Elon
gets $1
Musk.
billion?
This is Elon holding his
I'll
company
say we're
bankrupt.
also not
Yes.
off the record. We're still recording. So anything anyone says right now will be uploaded to YouTube. Just
That's
a
all right.
disclaimer.
Fair
Just
point.
a question.
I don't actually have $1 billion either, so.
No.
Roger, maybe this would be a good time, since we are now officially back from break, to I don't know if it was Eddie's question or your question, Roger.
Sure. I want to reiterate, Eddie, help me when I go astray here.
Yeah.
We did some preliminary work with Milliman, and I think for those of us who are on the work group, was an understanding that was the first step to help guide our work. And there is, resources aside, much work to be done in that area still with respect to the benefit design issue, with the benefits, services, and the integration of that with cost sharing. And we talked about that a little bit in our straw poll one, but that work remains undone. And at some point in time, it's going to be critical to bring that work forward again as the commission goes forward to try to build the system. And I can get more specific later. I don't mean to take our time on that. I just think to acknowledge from at least, and if I'm speaking for both of us, we feel the work is very much undone. It was a preliminary step, and there is significant work needs to be done in that area, and we can certainly talk about that offline about what we might each think what that means. Eddie, am I saying that?
Yeah, you are. I mean, I think there's an offline conversation on that, but there is a large piece of work that's there. It still hasn't really been unpacked. And I think we summarized it rather quickly and then kind of pivoted and moved on. So, which I thought that was a cornerstone of some of the information that we were providing for universal design.
Eddie, are you referring to, and Eddie and Roger, referring to work that has been done that was embedded in Milliman's work? Or are you referring to an additional body of work that might be performed?
In the original report and in the original discussions with them, this was just the first piece of the work. So there was, I think, some documentation and then a follow-on proposal for work to do.
Okay.
And so is part of the question if benefits and services will be revisited again in FTAC's work plan?
Well, in the financing part, this coming up with a number and then how you're going to split that number, so how any state is going to accomplish this. And, once this moves forward, this becomes a really big part of that discussion.
Okay. I guess the please correct me if I'm wrong, if I'm interpreting this wrong, but it's kind of an ask to see if either we revisit it or look to see where the additional work that you're noting would be done in kind of FTAC's work plan and how that fits in with kind of the discussion, as we're moving towards provider reimbursement, is, I guess, one clarifying question. Are you thinking that the additional components of financing would need to be completed prior to beginning discussions of provider reimbursement, or it's just flagging that there's still some key pieces of that discussion that need to be picked up at some point?
Oh, those can happen in parallel, and they're almost separate discussions.
Right. Okay.
Ross, I'll give a real simple example. I believe the commission made at least when I read that document, they said, I know Medicaid's aspiration, whatever that means, but we're landing not on Washington's essential health benefits like some other states did. We're landing on UMP, Classic plus dental. Milliman never costed that benefit out. They did a hybrid for us. So, that's an example, is to say, well, what does that thing cost? Because I won't get into the detail, it was a hybrid. So that needs to be done. And then the question that sits around that is we laid out some cost sharing principles, but how do you try to kind of estimate that? That is not done. And those pieces need to be there because at some point in time, you got a PMPM. Well, how much is that times the number of people? And we don't know what that PMPM is. The minimum work is by design was incomplete in that. It provided a decision for the commission to make. And that work needs to be at some point in time completed before people start moving on, cranking other numbers.
Yeah, you're making sense to me, and I guess but that is something that we could accomplish through the second actuarial analysis. I don't want to say it's necessarily going to be done through Milliman, but through the additional analysis through the OIC proviso funding, that these are the types of questions that we need to have an economic or actuarial analysis done to kind of provide the full set of information for the commission and kind of the ultimate recommendations. Is that?
That's part of it, yes. That's
Okay.
a critical step, yes. All right.
And I don't want to speak for Mary, so Mary, please correct me, but that seems like, I know part of, the work moving forward is working through FTAC and the commission on identifying the next set of questions that we will have economic or actuarial analysis done with that 250,000 from OIC. So that seems like it would fit really well into that conversation when we're identifying those questions and what remaining analyses we need to do.
Yep.
Does that make sense to other folks, Mary?
That makes sense to me. And I just realized I said that during the break I was going to go find the proviso wording, and I didn't do that. But I did make myself a cup of coffee. So sorry about that, everyone. We can get that out to you if you want to see it.
I'll put that in the chat while we're moving on to the next.
Yeah, I would say this, what we're discussing today is well within the scope of that proviso language.
Okay.
Sorry, Pam, did you feel that the Milliman work and what we delivered to the commission was fulfilled, or I never really got a sense of that? I'm not sure I'm hearing you.
Oh, you're on mute, Pam.
Not. Are you asking me if it
Yeah,
got
I mean,
pulled?
just because you have a good view from where you're
Well,
at.
I was just helping out a little bit on facilitation. I was not privy to what the commission asked for. And so I was just doing what we needed to do at our meeting. Whether or not it suits what the commission asked for, I think would be up to the staff to interpret because they're the ones who are really handling the go-between at this point.
Okay.
I think it is what they want at this point.
Okay, it's good.
So, Mary, what do you think?
Yeah, I mean, that has been my impression that it answered the questions to the extent that those are the, I mean, it
Yeah.
gave them the information they were looking for, is what I
Yeah.
should say. But, as we move forward and we know we have this OIC proviso funding, there will be discussions at FTAC and the commission and staff and OIC staff of where that money might be spent. So, I mean, it may come up other ideas or, further along in this body of work. We don't know where we will land on that.
Mhm.
Because it would be interesting, I mean, looking at the hospital payment approach, I mean, if there's some study or enforcement mechanisms that you would want to do, or, any one of those could take up some of that. And I think the work that we currently have was answering a very large question, and these are going to be more targeted at, kind of pieces that can be implemented by themselves and stand on their own. And as case in point, the reference-based pricing that's already there. So
Yeah.
Okay.
This makes a lot of sense to me in terms of it sounds like we're kind of restarting the question of what do we want to utilize the additional proviso funds to analyze in it. It sounds like a suggestion from Roger and Eddie that there's still more work to be done with the benefits services area. Is that?
Yeah, so I was thinking that was my pitch back. How we use the money is obviously a separate conversation. I have my own biases in that, of course, but I want to read it just again, acknowledge what Eddie had said is that body of work that served the commission to make a decision. They selected a benefit design, UMP Classic, good, plus dental. So, but we got at some point in time, the Royal, we got to say, okay, what does that cost out? What does that cost? And that's part of this other completed work that needs to be done. That's going to, drive our subsequent work or whoever's subsequent work. So if that's acknowledged and recognized for right now, it's fine. I don't mean to take any more folks' time on it.
No, I mean, I appreciate you picking it up. It's been a topic that we've been discussing about when to kind of start having these conversations about what the actuarial or economic analysis will be. So again, I don't want to speak for Mary, but perhaps this is something at the next meeting that could be, a topic is starting to think about what we would propose for that analysis so we can get that to the commission and get that ball rolling.
Yep, I agree.
Thank you, Eddie, and thank you, Roger. And Pam, thank you.
Okay, now we are 12 minutes away. We're wrapping up at 4:30. The next topic we had is kind of another big conceptual, what's in scope and out of scope for the principals. And I'm thinking about the time and thinking about the conversation, and I'm wondering, folks, you tell me, should we go over it high level, speedy quick, and take it up next time the committee meets? Do we want to just let it go? I'm not sure what works for people or how deep we can get into it at this point. So open to suggestions.
I have put up my hand. I think the principals are I sort of feel like the last discussion would have been easier if we'd done the principles first, but maybe I'm wrong. And of
Well,
course,
I was getting that feeling as we were having the discussion. So,
I regret not having a chance to have gotten into that. And that also, I'm hoping it would have engaged more members of the committee a little bit more than kind of looking at the in and out list. But so whether or not we have it now or next time, if we do have it next time, it may be we might look at some materials before the meeting or have a little bit of grounding in the meeting about provider payment approaches. And then that might make it easier to link back to, some of the topics that Roger's bringing up are decisions you would make before you started to decide how you're going to pay providers. You would decide certain things. So we are a little bit out of sync with some decisions, but I don't see how that's avoidable.
Okay. So anyone else want to weigh in? It sounds like perhaps we do a little more framing and a little more grounding and come back with this topic in January at the top of the agenda or early on. We don't have to be tippy top, but early on in the conversation.
Seconded.
Yeah.
Okay. I don't know how that's sitting with people. I mean, sometimes even with my afternoon coffee, I'm not sure how fast we could get through this conversation. Roger, did you want to add something?
Well, just to maybe just to help, kind of stimulate this conversation, there's some follow slides here. Could we just kind of, at least the time allotted, roll through those quickly and see what it evokes in our conversation?
Sure. I mean, we can go through them speedy quick. I don't think we're really going to have time to discuss, and I hope there's enough context, provided from today, from our previous discussion. We can go through them kind of quickly, knowing that we're going to look at them with more context and in greater detail in January. That sounds okay to folks? Okay, let's go through it real quick. If I could have the next slide. Thank you, Audrey. So why we are talking about guiding principles is this came up during the FTAC meeting, the first step to developing the recommendations. Our cost sharing principles, which were developed by FTAC and adopted by the commission, are a good example of, I think they're a good example of specificity and, what level are we talking about things when we come up with principles. And then we have some examples as a starting point. These are things pulled from disparate places, which I think will take some discussion to actually bring them all together. Things from a previous FTAC discussion, the Washington Health Security Trust Bill, and feedback that we heard from the commission. So if we can go to the next slide. Nope, let's go to the next one. I want to go to, sorry, we're speeding through. Here's our example. This, if you recall, it took us a while to kind of hit the right level. And this, I think, goes back to a lot of the conversation we had earlier today about how in the weeds are we going to get. And I'm just going to use the very first one as an example. Avoid creating barriers to care by considering, among other things, income thresholds and exemptions for cost sharing. So again, this is related to cost sharing. We did not say there should be zero copay for people up to 250% of the federal poverty level. It was not that level of detail. It was more, really take away the barriers, consider people's income, adjust the cost sharing. So I think that's probably a good level of detail to aim for with the provider reimbursement discussion as well. And I think we actually started out with 7 or 8 of these, maybe 9, and we winnowed them down to 5. So go to the next slide. So from our previous FTAC discussion, these are some of the things that came up that a reimbursement model should be or how it should function. Administered and regulated by the state, not by the providers, not by the insurers. Make it mandatory. Overseen by an independent regulatory commission, accountable to the public, designed to contain cost growth, designed to improve financial stability of the healthcare system. So these are, some of these are very big regulatory, that kind of framework thinking. The next slide, and I know I'm going through these fast, and I realize they might not be sinking in. This is part of the public comment we received. This is adapted from the public comment about the Washington Health Security Trust. I tried to look at what we had as in scope and out of scope for now in the previous discussion when I made these slides, and sort of said, okay, so which ones fall where? Which ones would still fall with the potentially in scope? Which one is the later discussion? The potentially in scope, we landed encourage care coordination and integration and reward time spent educating patients. All right, next one. I'm not giving people too much time to think and absorb. This is your preview. Things we heard from the commission. Again, I know we've talked a lot about this today, incorporated administrative simplification into the principles. Consider the differing perspectives from providers. And so we thought, well, maybe we should revisit the panel discussion we had earlier this year, rural health providers and hospital administrators, see what they had to say, maybe try to incorporate some of their ideas. And the next slide, I think, is more commission feedback. No, it is not. It is the discussion that I think we will hold for a later date, and we will send these out with more detail, encourage people to look at them before January. Just asking which of these principles feel good as a starting point, what's missing, and how do we balance reimbursement principles and participation principles? Because this body of work is reimbursement and participation. So I know we are not going to get to any of that right now. So thank you for listening as we went through it. It will come your way again with greater context and an earlier discussion. And Roger.
Yeah, I guess two quick ones to throw out there for thought. One is that I think we said implicitly, but that reimbursement is not tied to lack of better words, eligibility. And what I mean by that, it's a common reimbursement system across for all individuals enrolled in this system. So we don't have Medicaid rates and Medicare rates. It's a single rate structure for all persons enrolled in the system. It's kind of a foregone conclusion, but it is a guiding principle. I throw one out that's a little bit more specific, and it's this notion that's kind of controversial as site neutral reimbursement. And I bet Bob will smile at that one.
Okay.
Which is a controversial issue that, I think one of the guiding principles, like for Medicaid, is you pay the same folks for like services. The example in the Medicaid world is if you have an A.R.N.P. doing, primary care work, they're paid the same as a family practice doctor. They're doing the same activity, same billing codes, et cetera, that they get reimbursed the same level.
Okay, thank you.
I mean, there's a bunch of those, but I think those are two that I like to just throw in there for further deliberation.
We're going to be revising these slides so we can add that to the FTAC input slide. How's that? And then we can have the longer conversation next time we're all together. But thank you. I appreciate your adding those. And Ross, we are at T-3 minutes. I don't know if there's any other. Oh, Bob.
Yeah, I'm just wondering, is there a chance between now and January? I mean, it's 2 months away. Could we have a separate meeting with whoever wants to participate to kind of drill down more into, and my understanding is you're looking for principles related to payment, principles related to the reimbursement system. I'm not sure why we threw in cost sharing earlier in that. To me, that's outside of principles associated with payment. So I'm just wondering if we might be able to have a separate meeting to kind of define these things a little bit more specifically.
Cost sharing was meant as an example of here's a set of principles we did before.
Oh, okay.
That's why that was in there.
That confused me. I'm sorry.
But no, point well taken.
Principles didn't apply to reimbursement.
Yeah,
so I'm like we're all over the place.
Yeah, so, if people want to work with staff on this between now and January, we are all ears.
Yeah, I would suggest that so we don't have, we're kind of deer in the headlights here because I think there's just not enough structure or a definition about what you're looking for from us.
Yeah, I agree with Bob. I appreciate those remarks.
Yeah. Okay. Bob, would you be part of that?
Yeah, absolutely.
Thank you.
And let's do it before Thanksgiving. I just think this whole process, I understand people want to be deliberative, but this just takes a long time, and I don't think it needs to. And so anyway, anything to kind of help speed up the discussion a little bit and put a
Thank
little
you.
more structure on it, I think would be very useful.
Thank you. Do we have other volunteers for that one? All right, we got Bob and Roger.
So this is a meeting that's not part of our formal meeting series.
Right. It won't be formal meeting. It'll be, let's hash these out and come the next time this comes back to the full committee, which is January.
Oh.
Things are much more formed, much more thought through, kind of not scoping it out in real time, but here are some recommendations, and then FTAC can react to it. And my hope is that it would be circulated. Here I am promising a lot of things, and what is it, November 6th? Hope to circulate it to members before the meeting, if we can.
Eddie's volunteering. I can see his eyes.
Yeah, I mean, yeah, of course I'm curious. There.
Okay.
Enough said.
Thank you, Eddie.
I do just want to acknowledging we have limited staffing resources. As mentioned, Ellie is transitioning. So, to the point you made, Mary, if I'm understanding correctly, we want to establish a pseudo work group between now and January to review some of these principles in scope and out of scope, which seems reasonable, but also acknowledging that we do have less resources. So I don't know if it'd be helpful, Mary, for us to take that back and see if it's something that we're able to do before promising.
Is it principles only, or principles and in out of scope? What were you suggesting, Bob?
Well, I was suggesting focusing primarily on the principles.
Okay.
Because the topic is reimbursement, and then we can decide what in and out of scope later, I suppose. But let's focus on principles as it relates to reimbursement. I got confused when you brought up cost.
Oh, it's okay.
Yeah.
It's late in the day.
Yeah.
To try to sell Bob's idea a little bit to staff, it actually could save staff time if you put it together. Yeah.
Good sell, Pam.
Thank you to folks.
In terms of staff commitment, in terms of staff time and commitment, I think it just show up for the work session, and we can kind of hash through some of these things and outline it. And then I'm happy to spend my own time helping you with more technical issues or whatever. I'm happy to help out however I can to supplement your lack of resources. So, but anyway, I think we just need that framing conversation, because otherwise we're just kind of deer in the headlights.
Thank you.
So that sounds like it. So we can do a work group, and it's really just creating some time and space for that work group to go through the principles and flesh those out a little bit more. And then would come the next FTAC meeting, we'll have a little bit more of an understanding to kind of facilitate that discussion. Sorry, I apologize. It's kind of taking us through each step there, but that's my understanding of kind of our goal.
Yep.
Okay.
All right. Thank you all very much.
Thanks.
Helpful discussions today. This stuff is hard to frame, so input is appreciated, and people volunteering to help us out is also much appreciated. So thank you. And Ross, I'll send it back to you for reals this time.
Thank you, Mary. Well, I just echoing Mary's sentiments, really appreciate folks' time and energy and participation. Like Mary noted, I know this is technical, and with today's topic, there was some ambiguity. So really appreciate folks working with us through that and giving us some pointers about how to hopefully make this a little bit easier to work through. So greatly appreciate that. We'll share an update regarding this meeting at the December Universal Commission meeting. That's on the 11th. Our next FTAC meeting will be Thursday, January 15th from 2 to 4:30. As staff, we're going to talk about the recommendation to form a work group to discuss the principles around reimbursement, and hopefully follow up with those folks that signaled interest at today's meeting. And with that, I'll adjourn today's meeting at 4:33. Audrey, if you could stop the recording, and wishing everyone a great rest of the day and weekend, and I look forward to seeing you soon.
Okay. Thanks.
Thank you, everyone.
Ross, Mary, everyone.
Bye-bye.
Bye all.